This is Dr. Nam Lee from Lee Acupuncture at the Newport Beach. And I have a special guest, Dr. Frank Yelian. Hi, Doc.
Hi, how are you, Dr. Lee?
I am doing well. Thank you so much for being here. Actually, I have another interview with Dr. Yelian and then discuss about his passion for this reproductive medicine field and specific about his precision IVF. But today, the reason I invite Dr. Yelian, because I have patients asking about first embryo issues and an egg quality issue. Since Dr. Yelian is expert in that both field, he's an embryologist and reproductive endocrinologist. So I invite Dr. Yelian. Thank you so much, Doc. I know you're so busy.
Thank you.
So let's go to the question quick. So my first question, how do we grade the quality of embryos? Then what grade of embryo is good enough to transfer?
That's a very good question. And in terms of grading embryo, there's two different grading system. And obviously based on the day 3 embryo on day 5 embryo. So day 3 embryos, and so we're using a number, for example, 811, consider the highest quality embryo. And so you can be 812, a little bit lower grade, and 822, or 832, or 823, and or 833. So basically, those are the numbers give you a embryo grade for day 3 embryos. And so the first letter 8, which means 8 cells. The second number is the cells symmetricity and how the cells of the 8 cells, how the equal size. And so if highest the symmetricity will give 1, and the lower the symmetricity and will give 2, and extremely asymmetric, and this will give 3. The third number is fragmentation. So how many fragmentation of the embryo has? So 1 is best, and 2 is the middle, and the 3 is the lowest grade, which means they have highest fragmentation. So as I said, 811 is the best grade embryo for day 3 embryo. And sometimes you may see 911 or 1011 or 1211. So which means the cell number is 9 cells, 12 cells. So all this good signs. And but on day 3, we would like to see between 8 to 10, 12 cells. This is a good number. But the cell number is lower, like less than 5 cells, and then indicating the embryo development a little bit slow. So those is not such good grade embryos. So that's grading system 1 in terms of grading day 3 embryos. For grading day 5 embryos, and based on morphological looking, and so we can see 4AA, and the 4 is depends on the embryo size and the expansion, and so this is a normal size of a day 5 blastocyst. We call it 4. AA, which means the best quality embryo, and the first letter A, which means called the inner cell mass. So this is the cell eventually become a fetus, and so there's a good cell number. So we give A. So if there are fewer cells, we give B. If very fewer cells, we give C. Mm-hmm. So the second letter is in terms of the outside layer of the cells, and called the trifective cells. So those cells eventually become placenta. So if you have more cells, we give A. If less cells, and we give B, and there's fewer cells, give C. So for the day 5 blastocyst, and so 4AA is defined the best quality embryos, and the 4AB, 4BA, and the 4BB, and the 4BC or 4CC, and the 4CC relatively lower grade embryos. So those are the purely based on morphological grading system, and it's very important. I need to emphasize is embryo grading, and just seeing the fewer cells and more cells. That's only correlating the probability of the embryo can result in implantation. But those embryo grading has no correlation with whether embryo could be chromosome normal or chromosome abnormal. So there's no correlation. Mm-hmm. So I remember in the past, I had a patient who had the kidney transplantation. And so she's 40 to 41 years old. And so she did the self-IVF cycle with us. And it turns out there was, so she has 4AA, 4AB, 4BA, 4BB, and 4CC embryos. And the 5 embryos she made. And so we only can biopsy for a high-grade embryo because 4A, 4B, we can do biopsy, we can send out for PGI testing. But the 4CC was not able to do biopsy. And turns out we sent all the 4 embryo for testing. Then unfortunately came back all the test embryo abnormal, chromosome abnormal. So the patient is very disappointed, and so she asked me what to do. So I said, you still have a 4CC embryo. Even if the embryo was low grade, we cannot do biopsy, but the embryo still have a chance to be good. So okay, so we decided we transfer the embryo. So that transfer results pregnancy, and she take a home baby, very healthy baby boy.
Wow.
So which means that grading has no correlation with the embryo chromosome normal or abnormal. Just means the embryo has a fewer cells and the lower chance of results pregnancy. But if they're pregnant and the baby is equally healthy.
I see. So my question was, so you can actually transfer, like, because you can not the grading level.
Right. That's correct.
Okay. So then now I come into the mosaic embryo, even more confusing part. So what is a mosaic embryo? And then do you have any opinion about like transferring?
Yeah, mosaic embryo is also the controversial topic for the medical community. And so for all the IVF doctor, we always are concerned about whether should transfer mosaic embryo or should not transfer mosaic embryo. So by definition, the mosaic embryo, which means when we do cell biopsy, and so remove some cells for trophic biopsy. And for example, if we remove 5 cells, give you an example. So if we send these 5 cells and the DNA for testing and came back and maybe 4 cells are normal, only 1 cell came back abnormal, or vice versa, and maybe 2 cells are abnormal, 3 cells normal, or 4 cells abnormal, 1 cell normal. So those is we consider mosaic, which means for the same biopsy, and some cells normal, some cells abnormal. So in this case, and so now the decision is leave the doctor, and so sometimes it depends on severity of a mosaic, and also to see if this mosaic embryo is because of mosaic on the chromosome number 21. So we tend not to transfer the embryo because that could be risk of the transfer results embryo baby with Down syndrome. So because that transfer can result live birth. But if the mosaic embryo for number 1, number 2, those embryo we may consider transfer because we know if you have a complete abnormal chromosome number 1, number 2, those embryo cannot survive to term. So you will not deliver baby with genetic disorder or have a mental retardation, for example. So for those kind of the case, we may consider to transfer those embryos.
Totally makes sense. This is also like a fresh embryo transfer and then frozen embryo transfer. I know we do a lot of frozen embryo transfer at this time, but I see sometimes people do combine together.
Yes.
So do you have any pros and cons for this too?
Actually, very, very good question. And I just came back from the chest procedure room. And so the patient who did the egg retrieval 3 days ago, and we got 5 eggs and made 3 embryos. So she was considering to do fresh embryo transfer. But when I go back to look at her and uterine lining, found her uterine lining not optimal. So the thickness is not good. And so then I talked with her. I said, those embryo I can transfer freshly, but I think for you and the best chance to give you pregnancy is we freeze those embryo and we transfer next cycle. So I just came back from the lab. So I think this is a perfect discussion for this topic. This is actual patient. So in terms of fresh and frozen, and it usually depends on number 1, and the patient age and the patient condition. But in general, and so if the patient the cycle using no medication with deteriorating of a uterine cavity condition, so those kind of cycle we may consider fresh transfer. And so for example, we using Menopur or Gonal-F, and so we did not using clomiphene and for the cycle stimulation. And if patient made 1 or 2 embryos, and we may consider to do fresh transfer if patient does not want to do the genetic testing. And however, if patient is using clomiphene in the cycle of treatment, because we know clomiphene has an anti-estrogen effector, so may cause the uterine lining thinner. So when the uterine lining thinner, so those embryo transfer may result in poor implantation. So in terms of the patient age, and so some of the women, and so if their age is a little bit older, and the 44, 45, 46, and for those conditions, and if her uterine condition is good, And if patient wish to do fresh transfer without it to freeze the embryo, and also she does not want to do PGS testing, so those embryo can consider transfer as well. But in general, if a woman over 40 years of age, and I strongly encourage them to do genetic testing for embryo. So we want to make sure transfer PGS normal embryo that give them a high chance of success and a lower chance of miscarriage. So in the old days, and so you probably see probably 15, 20, or 30 years ago, and most of the cycle transfer or do fresh transfer for two reasons. Number one is because the freezing technology is not very sophisticated, and so some embryo, if you freeze and thaw, the embryo may not survive. Mm-hmm. But nowadays, and freezing technology is very sophisticated, and they use especially using vitrification, and the embryo freezing survival rate almost 100%. So that's the freezing and thaw should be very safe process. But the key thing is that we want to make sure patient condition is the best, most optimal for embryo implantation. So because of this, and so especially we want to do PGS testing, it may take a longer time for PGS testing results come back. So this is why we prefer to freezing the embryo than to do frozen embryo transfer. So nowadays, I think that I would say in the United States, maybe 80% of the center, they do frozen transfer instead of only 20% to do fresh transfer. But I think both equally can be successful, just patient dependent and situation dependent.
Especially patient condition is good and healthy, and then fresh is actually there's a chance. And as you said, it's natural IVF. That's what you do, less medication. Yes. So integrity of the uterine cavity is there. So I think that even more actually option. That's excellent.
Right. Yeah, exactly. For the natural IVF, and those patients will be more optimal for doing that fresh transfer.
I guess so. This is also kind of confusing. Day 3 versus day 5, because we do all day 5 is good, but also I'm hearing from some Asian country, they do actually day 3. And it's kind of new to me. And do you have any opinion about day 3 and day 5?
And so day 3 embryo is, as you see, the embryo developed day 3, and which is I talked earlier. So if you look at the microscope, the cell embryo be 811 or 812, those kind of 8 cells, 9 cells, 10 cells. So those kind of early stage. So if the day 3 embryo, if you catch another 2 days, and day 5 or sometimes day 6, those embryo become a blastocyst. So day 3 embryo transfer is very common in the Asian country, and especially for those countries, the PGS testing is not allowed for everyone. So to my knowledge, for example, in China, there's so many IVF centers, but only few centers allowed to do PGS testing for every patient. So because of this, and the PGS testing is limited. So for that reason, and so doctor, the reason to do day 5 transfer, and obviously we know not all the day 3 embryo can make day 5. So in general, in the average lab, obviously depends on patient age and also her egg quality. And normally I would say maybe 50 to 60% of day 3 embryo can make day 5. So it is from culture day 3 to day 5 is a natural selection process. So if patient have many embryos, and we prefer embryo culture day 5 because we can select the best embryo can make it. And also, if an embryo made day 5, then we can do genetic testing of the embryo, and then even give a patient even higher chance to be successful. And however, if a patient is very young, and her like younger than 34 years of age, and her chance of an embryo to be healthy are very good. And for those individuals, PGS testing may not be necessary for them. So if that's the case, then chance of day 3 embryo may be better for her, especially if patient only have 1 or 2 embryos. So if your patient only 1 or 2 embryos, the reason we do culture day 5 is try to give a selection process. So that for patient 1 or 2 embryo, there's no selection needed. So just put 1 or 2 embryo back and give patient the best chance. So for those individuals, we prefer day 3 transfer. And for older women, especially a woman over 43, 44, 45 years old, because those women have a probability of embryo to be chromosome abnormal are very high. So if you transfer embryo, the chance of conceive naturally be low and also have high chance of miscarriage. So for those individuals, we prefer those embryo go to day 5, 1 selection process. Number 2, then we do PGS testing to make sure the embryo has no chromosome abnormality. So then we transfer those normal embryo, then patient have high chance of pregnancy and lower chance of miscarriage. So for those individuals, day 5 embryo transfer may be better option.
Absolutely, personalized approach.
Yes, exactly.
I totally agree. So this is one, this patient, she's 44 years old, and she had the last 2 cycle egg retrieval was actually failed. So they couldn't really have any egg. And she's very disappointed. And her case is actually minimal stimulation though. So she's wondering, so this is now already she failed 2. It means it's gonna be go downhill. So she has to look into maybe different option, or still she has a chance to do like a 2 is maybe not that bad sign. Do you have any opinion about?
Yes, I have a strong opinion for this patient, and because first of all, and so I really want a patient to be persistent, don't give up, because having a child, and we live life only one time. So since this is your only chance and to have a biological child, you should try your best, because you can use a donor egg at any time, any given age. And so you probably heard that a woman 74 years old still can carry pregnancy. So you're only 44, and even if you failed 2 times, does not mean you will not be successful. And the reason patients fail 2 times mainly because of women at age 44, the probability of embryo to be chromosome normal is only about 1 in 10. So every 10 embryos she made, only 1 chromosome normal. So obviously she tried 2 cycles. Most likely the embryo she made was chromosome abnormal. So obviously will not result pregnancy. So should be continue, try, don't give up. And I tell you a story. I had 2 patients, and both are 45 years old, came to me. And one patient, so actually she was Asian, and so her ovarian function was not so good. So we did 3 mini IVF cycle for her. And after 3 mini IVF cycles, she only made 1 blastocyst. And the blastocyst was not good grade. It was a 4BC. So she, after finishing the cycle and only made 1 4BC embryo, she said, Dr. Ilian, what should I do? I think you have this 4BC embryo, let's stand up for testing, because for your age and testing is very important. So we did, and the embryo came back, that was normal embryo, only 1. So theoretically, her chance of embryo to be healthy is only 1 in 10, but she just won. And the embryo transfer results very healthy baby. Another patient, also 45 years old, and she did IVF with us, and the same conversation, 45, I told her, your chance of embryo to be healthy are very low. And she said, I'm a quitter, and if I'm failed a couple of times, I will quit. But the only way to keep me continue try is I bank in the embryo. Don't test them until I made enough embryos, which she did. She persistent. So she finished 9 egg retrieval cycles, finally banking the 14 blastocysts. So she sent all the 14 embryo for testing, came back only 1 normal. The normal embryo was from her very last egg retrieval.
Wow. Wow.
So that transfer results pregnancy. Actually, she came to us to our webinar to share with her a story. So I think how she persistent for this have a successful results. So from these 2 stories, I want to share with what the one philosophy, which is embryo to be normal or abnormal is a probability. The probability at her age, 44, is 1 in 10. So as long as she's not giving up, and every single embryo have a chance to be a normal embryo. So if she has a normal embryo, the chance of she getting pregnant are very good.
Wow.
So obviously, and so if she, because of financial reason or because of other personal reason, she really want to have a child right away, maybe she should consider using donor egg, if the donor egg is an acceptable option for her.
Sure. So since we're talking about like the egg quality, and this is my last question, and I strongly, if I do more and more, I'm noticing if you can bring your blood sugar level more regulated to do all different exercise and nutrition, and then we are getting old, so if you can overcome those oxidation, like anti-oxidation, maybe you can do supplement or other stuff, and we have a lot of acupuncture. So do you think that those are 2 components? I'm strongly emphasize blood sugar regulation, and then more like an antioxidant will help the egg quality improvement?
That's good question. I don't know, and because I haven't done those kind of research myself, so I really have cannot comment for that the concept. So I think obviously, and the blood sugar level, and in general in a normal person, and I believe blood sugar level should be self-regulated, because depends on when you are eating sugar, and so usually after 2 hours, sugar level will be back to 100 or lower. So I think in general, so because the body produces insulin, can be regulate the blood sugar level for naturally. And so whether because of antioxidant and for those kind of supplements may help in general health, and but whether we be results egg quality, that's still may be under investigation. So I think I should do more research for that topic.
True. Thank you so much for all this valuable information, Doc. I mean, I know as I said, you're a really busy doctor. So can you tell us, our audience, how they can find your practice?
Oh, find a live IVF center is very easy. And so if you Google www.liveivfcenter.com, and so you should be able to go to a website. And also our phone number is available. You can call 949-788-1133 to reach us.
And then you have a webinar, I think a monthly webinar. They can
actually we have
in.
a webinar this week, and so this Saturday. So if people wish to attend our webinar, feel free to go to our website and register.
Thank you so much, Doc. I really appreciate it. It's just tremendous, great information. Thank you.
Thank you, Dr. Lee, for inviting me. Nice talking with you.
Thank you.